Scott Brown's Rhinology, Chapter 87, Anatomy of the Nose and Paranasal Sinuses. We are going to learn about nasal septum. Nasal septum. The nasal septum serves many functions, including separation of the nasal cavity into nasal cavities, support of the nasal dorsum, and maintenance of the nasal tip, and forms part of the nasal valves. Deviation of the nasal septum can lead to significant nasal airway obstruction and cosmetic deformity. The nasal septum consists of a bony, cartilaginous, and membranous portion. The bony portion is comprised of the perpendicular plate of the ethmoid, vomer, maxillary crest, and palatine bone. The perpendicular plate of the ethmoid forms the upper one-third of the nasal septum. It is continuous superiorly with the cribriform plate and crista galli and abuts a variable amount of the nasal and frontal bones. Posteriorly, the perpendicular plate articulates with the sphenoid crest, posterior inferiorly with the vomer, and anterior inferiorly with the septal cartilage. The vomer forms the posterior and inferior nasal septum and articulates by its two ala with the sphenoid rostrum, creating the vomerovaginal canals through which the pharyngeal branches of the maxillary artery travel. The inferior border of the vomer articulates with the nasal crest formed by the maxillary and palatine bones. The anterior border articulates with the septal cartilage, and the posterior edge of the vomer forms the posterior free edge of the septum. The cartilaginous portion of the nasal septum is composed of the septal or quadrilateral cartilage. The quadrilateral cartilage is bound firmly by collagenous fibers to the nasal bones, perpendicular plate of the ethmoid, and vomer. The septal cartilage is continuous with the upper lateral cartilages towards the bridge of the nose. A projection of the septal cartilage called the sphenoid process and septal tail extends posteriorly between the vomer and perpendicular plate of the ethmoid. The septal tail can serve as an additional source of cartilage to harvest, especially during revision rhinoplasty. The inferior attachment sits within the nasal crest of the maxilla and is bound by looser connective tissue, creating a pseudo arthrosis. This joint allows mobility of the septal cartilage base during flexion, thereby reducing the risk of fracture or dislocation with trauma. The membranous septum is a segment of connective tissue between the caudal portion of the septal cartilage and columella. Figure 87.1. The cartilaginous and bony components of the nasal septum. Nasal spine of frontal bone, nasal bone, medial edge of upper lateral cartilage, lateral nasal cartilage, septal cartilage, membranous septum, medial crust of alar cartilage, vomeronasal cartilage, incisive canal, crest of maxilla, greater palatine foramen, crest of palatine bone, vomer, rostrum of sphenoid, perpendicular plate of ethmoid, cribriform plate, crista galli of ethmoid bone, and frontal sinus. Coronal CT of septal swell body shown in the arrow. The nasal septal swell body is a widened region of the anterior nasal septum located anterior to the middle turbinate at the internal nasal valve. The histological analysis of this tissue demonstrates an increased amount of venous sinusoids and fewer glandular elements compared to adjacent septal mucosa. The high proportion of venous sinusoids suggests the capacity to alter nasal airflow in a similar manner to the inferior turbinates. Blood supply of the nasal septum. Both the external and internal carotid arteries contribute to the vascular supply of nasal septum. The external carotid artery branches supplying the septum include the sphenopalatine and greater palatine arteries. Branches of the internal maxillary artery. The sphenopalatine artery supplies the posterior inferior septum by a branch called the posterior septal artery. The posterior septal artery is the basis of the nasoseptal mucosal flap, which is the workhouse for endoscopic skull base reconstruction. The greater palatine artery enters the nasal cavity through the incisive canal to supply the anterior inferior portion of the septum. The septal branch of the superior labial artery, branch of the facial artery, contributes to vascular supply of the caudal septum and columella. The internal carotid artery branches supplying the septum include the anterior and posterior ethmoid arteries, branches of the ophthalmic artery. The anterior superior and posterior superior portions of the nasal septum receive vascular supply from the anterior and posterior ethmoid arteries respectively. The anterior ethmoid artery, posterior septal artery, and septal branch of superior labial artery contribute to Kieselbach's plexus, which is located along the anterior nasal septum at Little's area. This region is formed by the anastomosis of these arteries, which terminate as a rich vascular bed of long capillary loops. Kieselbach's plexus is the most common location of epistaxis due to its rich vascular supply and susceptibility to injury due to from such factors as turbulent airflow and digital trauma. Box 87.8 Kieselbach's plexus is the most common location of epistaxis due to its rich vascular supply, confluence of the anterior ethmoid, posterior septal and septal branch of superior labial arteries, and susceptibility to injury from turbulent airflow and digital trauma. The venous system drains via the sphenopalatine vessels into the pterygoid plexus posteriorly and into the facial veins anteriorly. Superiorly, the ethmoidal veins communicate with the superior ophthalmic system, and there may be direct intracranial connections through the foramen cecum into the superior sagittal sinus. Figure 87.12 Vascular supply of the nasal septum. This is the Kieselbach's plexus, anterior ethmoidal artery, posterior ethmoidal artery, septal branch of sphenopalatine artery, septal branch of greater palatine artery, septal branch of superior labial artery. Lateral nasal wall and turbinates. The inferior, middle and superior turbinates are internal structures found along the lateral nasal wall. The middle and superior turbinates rise from extensions of the ethmoid bones, whereas the inferior turbinate is an embryologically independent osseous structure. The space between the lateral nasal wall and inferior, middle and superior turbinate is called the inferior, middle and superior meatus, respectively. Each meatus is associated with connection between a specific anatomical structure and the nasal cavity along a series of well-defined drainage pathways. The lacrimal duct drains into the inferior meatus approximately 1 cm posterior to the head of the inferior turbinate. Although not considered a true valve, the opening of the nasolacrimal duct is called Haysner's valve, which is formed by small folds of mucosa. The middle meatus forms the common drainage pathway of the maxillary, anterior ethmoid and frontal sinus into the nasal cavity. The superior meatus forms the common drainage pathway of the posterior ethmoid air cells. Turbinates are structures filled with vascular channels and venous sinusoids which serve to warm and humidify air and modify nasal airflow resistance. The turbinates continuously dilate and constrict under sympathetic control in response to environmental conditions. A process occurs every 0.5 to 3 hours in a normal physiological phenomenon known as the nasal cycle, results in alternating congestion and decongestion of nasal cavities. Turbinate hypertrophy is a common cause of nasal obstruction in which the turbinates are either chronically congested or hypertrophy due to allergy or non-allergic triggers as part of inflammatory rhinitis conditions. The nasal turbinates continuously dilate and constrict every 0.5 to 3 hours in normal physiological phenomenon known as the nasal cycle. Blood supply of the lateral nasal wall. Both the internal and external carotid arteries supply the lateral nasal wall. The sphenopalatine artery contributes the majority of the arterial supply to the terminates and lateral nasal wall. It enters through the sphenopalatine foramen, which lies just inferior to the horizontal attachment of the middle turbinate. The sphenopalatine foramen is formed by the sphenopalatine notch of the palatine bone in articulation with the sphenoid bone. The crista ethmoidalis is a small crest of the perpendicular plate of the palatine bone located anterior to the sphenopalatine foramen and serves as a consistent and reliable landmark to identify this vessel during endoscopic dissection. The sphenopalatine artery commonly branches laterally to the crista ethmoidalis with many variations in the branching pattern. In one cadaver study, 97% of specimens had 2 or more branches of the sphenopalatine artery medial to the crista ethmoidalis. It is critical that the surgeon is aware of these variations and controls all branches to ensure successful endoscopic ligation of the sphenopalatine artery for epistaxis. If more proximal vascular control is required, the internal maxillary artery can be ligated in the pterygopalatine or infratemporal fossa by removal of the posterior wall of the maxillary sinus. This is the vascular supply of the lateral nasal wall, anterior ethmoid, posterior ethmoidal artery, sphenopalatine artery, and greater palatine artery. Box 87.10. The crista ethmoidalis is a small crest of perpendicular plate of the palatine bone located anterior to sphenopalatine foramen and serves as a consistent and reliable landmark to identify the sphenopalatine artery during endoscopic dissection. There are often two or more branches of the sphenopalatine artery medial to the crista ethmoidalis. A small area along the anterior aspect of the lateral nasal wall is supplied by a branch of the facial artery. The inferior part of the lateral nasal wall adjacent to the palatine palate is supplied by the greater palatine artery. The internal carotid artery contribution is via the anterior and posterior ethmoid arteries, branches of the ophthalmic artery, which supply the superior lateral wall. The anterior ethmoid artery traverses 3 compartments of the head during its course from the orbit to the olfactory fossa and into the nasal cavity. After branching from the ophthalmic artery in the orbit, the anterior ethmoidal artery passes between the superior oblique and medial rectus muscles through the anterior ethmoid foramen. This portion is easily identified on preoperative coronal CT imaging. The anterior ethmoid artery travels through the ethmoid cavity obliquely in a posterior to anterior direction, either within the bone of the skull base or a mucosal mesentery. The artery traverses intracranially into the olfactory fossa through the lateral lamella of the lamina cribrosa. After entering the intracranial cavity, it gives off anterior meningeal branches before re-entering the nasal cavity through the cribroethmoidal foramen. Within the nasal cavity, it divides into the anterior and posterior nasal arteries. The anterior and posterior nasal arteries each give rise to lateral and medial branches that supply the lateral nasal wall and nasal septum respectively. The anterior ethmoidal artery is more difficult to access surgically, with only 20% of arteries found within mesentery that can be successfully clipped via a transnasal approach. Endoscopic removal of the lamina pepraceae allows identification of anterior and posterior ethmoid arteries between periorbita and skull base. Alternatively, an external approach via the modified Lynch incision can be used. There is considerable overlap between the internal and external carotid artery systems on each side and in between sides of the nasal cavity, which can complicate attempts at arterial ligation in the management of epistaxis. Box 87.11. The anterior ethmoidal artery is more difficult to access endoscopically as it is only found within a mesentery that can be ligated in a small portion of cases. An external approach using modified Lynch incision is often preferred method of ligation. Thank you.